I can understand why GPs get offended with you, because it sounds as though you're just dismissing their role in basically sitting down with their patients with all the complex mental health problems they've got, and you kind of suggest that they're just in that seat because of the money. What is your preferred role of GPs in mental health?
Let's take that issue. That's a really important issue. I love healthcare providers. They do take things personally. You know, I'm talking about these system critiques. They think it's a critique of them individually. Like, they take it in. That's really good, because they really do care about what they're doing. But on the other hand, I think they've got to think about the community in which we live. Now, one of the problems with fee-for-service is you can't help but be preoccupied with the small business that you run.
Yeah.
You know, because that's actually what you're doing, and the viability or otherwise of doing that. We sit here every day and think we should run a skin clinic or a Botox clinic because we can't work out how to fund mental health care. We know how to fund healthcare out of procedural medicine. You know, so there are all sorts of challenges for us in these issues. So when I'm being critical of fee-for-service medicine, I am not being critical at all of the providers of healthcare. They are working within the money systems that we run. All of the economies we work in work around the funding systems. All of those same doctors will have worked many times in fee-for-service systems or given their time in other settings. So what I'm talking about is the way you can use those systems. I've written about the way you can manipulate fee-for-service. As we've done with childhood immunisation or with other incentives. You can work with those packages to get the desirable outcome. It's not a critique of the individuals. If you go back to 2001, right, 25% or so of GPs were operating under the better outcomes thing, doing exactly that, getting paid for episodes of care, doing a really good job, doing the planning, doing the training, delivering the care, reviewing the episode, getting the additional payments. And I think it's those doctors who are most upset with the changes, right, because they seem to have lost something from what they gained for 2001. They were already doing a really good job, and they do a good job, and they continue to do a good job. Before 2001, for anyone who's got a memory that can go back more than 10 years, I discussed it with GPs endlessly. They did all this stuff all the time because it was good medicine. It's a nonsense to say you only do good medicine when you're paid for it. It's a nonsense. In the rest of what do you think GPs are doing every day of the week with diabetes and mental health problems, whatever, not doing it because they're not paid for it? That's ridiculous. They were doing it. What they want is payment for being more like a physician who takes time and less like a proceduralist who just chops things off all the time in all of their work. And that's a really big issue in general practice as it is in general medicine. I'm not a critic of that at all. What I'm a critic is of, and many GPs will tell you themselves, is not of those doctors, but of others who generated practice systems which spat out plans, signed, sent off, 150 bucks. You know, and you talk to many senior GPs and others who'll say, hang on. What happened here is, of course, the opposite side of the coin. The really good practice got lost. I don't accept this shorthand media description of cuts to better access. The growth in better access will continue to be massive growth. There is no cut. You know, cut requires you've had a haircut, something's gone down. If you just study the growth, the 400 million that is saved is in future expansion of the scheme, and trying to redivert some of that future expansion to actually those who don't currently get it. Young people, less income, rural and remote areas. You know, 2.5 times as many services go to those in the highest income groups as in the lowest income groups under the current arrangements. Okay, so I don't accept the cut argument. The redirection one, and the overall balance, I think this is one of the big unspoken things about it in Australia. You know, Medicare's a 40-year-old system in need of serious restructure for equity issues. So we continue to have a national health system that strives for better equity and better distribution, rather than what we really got is a 2- and 3-tier health system by whether you've got private health insurance or not, and also by where you live and what you earn.